All right, hi everybody. We're going to be talking about arrhythmias and antiarrhythmics. This is a really important topic that tends to be one of the more challenging concepts to get. We spend, I know, a good amount of time in class, but I think there's always room to really get a nice kind of refresher on this and spend some time on the concepts to kind of help you get the material a little bit better. So I think a good place to start is something that you've seen probably a fair amount of before, which is kind of the electrophysiology part, right? Thinking back to the action potentials, kind of what those mean. So let's sort of start with that. So you'll recall that there's two different types of fibers that can conduct electrically in the heart, right? We have fast response, and then we have slow response. Now the fast response fibers are going to be really throughout the heart, everywhere except for two places. Those two places where we see the slow response fibers are the SA node, which is the pacemaker, and the other one being the AV node, which is kind of that, I think of it as like the rate limiting step between the atria and the ventricles that's meant to really just kind of slow things down and kind of protect the ventricles. So the slow response fibers rely upon calcium, whereas the fast response fibers rely upon sodium. So let's just spend a couple minutes and talk through kind of what's happening, because really if you can grasp these types of concepts, then it'll make a lot more sense in terms of how the medications fit into this, how they work, and what effect to expect. All right, so we'll start with the action potential here, right? So it's going to look something like this for a fast response fiber. Right? So at rest, the cell is going to be on the negative side, and then once things start happening, it's going to be on the positive side. So at rest, right, we have different phases. We're going to call this phase 4. So then once the heart's able to start conducting an electrical impulse, we have phase 0. Which is the rapid upstroke. This is also known as the depolarization phase. Okay, so what's really driving that? So something has to happen for the cell to go from being very negative to being very positive. So in order for that to happen, so on the bottom here, I'm going to kind of show you what would be like a cell membrane. So if this is extracellular on this side and then intracellular on this side, we have these voltage-gated channels, right? Which when they open, they allow for the free flow of cations, right? So start with sodium, right? So sodium exists mostly outside of the cell, and it's going to want to move down its concentration gradient to come into the cell real quick, right? So it's going to be moving this direction. So in doing that, it's going to create phase 0. So what's next? So then these sodium channels abruptly close, right? And the cell starts returning toward repolarization. But this is phase 1, which is also called the peak. Right after that, we have what's called the plateau phase, which is phase 2. So the plateau phase means that we have these calcium channels, which are gated as well and start to open, right? So calcium is going to want to move the other direction. And then over here, we have phase 3, which is the refractory period. And this is also known as the repolarization phase. Okay, so what's happening during phase 3 that's going to allow the cell to return back toward its negative resting state? Well, in this case, it's the movement of potassium, which is going in the opposite direction. So potassium, unlike sodium, is mostly in the cell and wants to move out of the cell into the extracellular space. And then lastly, we're back to where we started, which was phase 4. So that's the fast response tissues. Now the slow response, coming down here, is going to look different. So this is going to look more like a sine wave. And remember, this is really just driven by calcium. So again, we still have resting, phase 4. We have a depolarization, which is phase 0. We don't have a 1 or a 2, but we have a 3, which is repolarization, which is And each of these are driven by the movement of calcium outside and inside the cell. And then we're back to resting. So really the net effect of all of these action potentials throughout the heart and all the different heart tissue is going to show up on a surface EKG that we can measure clinically. So let's talk about what those components look like, right? So in normal sinus rhythm, we have the major parts here, right? So we're going to start with the P wave, okay? What we have next is the QRS complex, followed by the T wave. So I think it's really important to remember what we're actually observing with these different parts of the EKG. So if you think about anatomically, and I guess physiologically, what's happening in the heart, right? So in normal sinus rhythm, right, we have the SA node. It's going to be somewhere up here, right? And it's going to set the tone, right? It's the pacemaker. It's going to propagate this electrical impulse, which is eventually going to hit the juncture between the atria and the ventricles. So we're going to have the AV node, which again is meant to kind of slow things down and serve as kind of the gatekeeper for the electrical impulses to go from the atria up top here to the ventricles, which are down below. So the signal's then going to cross through here. We have the bundle of His. And then we have these Purkinje fibers, which are going to traverse all the way up here into the ventricular muscle tissue. Okay, so for each cell, two things have to happen, right? Back to our action potentials. So the first is depolarization. But with the P wave, again, what should be depolarizing first, the atria or the ventricles? Well, again, under normal sinus rhythm circumstances, it's going to be depolarization of the atria. So what's next, right? The next thing you see is the QRS complex. Now, I will tell you that repolarization of the atria happens here, but you can't see it because what you're actually able to visualize on the EKG is the QRS complex, which represents depolarization of the ventricles. Because the ventricles have a lot more muscle and therefore can conduct a lot more voltage than the atria. So this is really what you're seeing here, ventricular depolarization, even though atrial repolarization happens at the same time. And then finally with the T wave, if we think through what has to happen next, well, the ventricles have to go through their complete phase and they have to repolarize. So hopefully that all clears things up and makes things a little bit easier to understand. And then the last part is tying this back to the medications, how they work, what classes they fit into. So we have that classification scheme that you should be familiar with called Vaughan-Williams, which basically organizes the different antiarrhythmics into different classes based on their primary mechanism of action. So the first includes class 1, which are sodium channel blockers. So where do these work, right? These are going to work on sodium, right? So if you go back to your action potential in fast response tissue, it's going to be right here, phase 0. So what we're doing with all the sodium channel blockers is we're trying to slow this upstroke, right? We're trying to shift this curve over to the right, like this. Now we have 3 different types of sodium channel blockers. We have A, B, and C. Right, a lot of these are really old antiarrhythmics that you're not going to see a whole lot in practice, so I want to point out what some of the key features are. Right, so, and I'll talk about why these are organized a little bit differently. So the 1As are unique because in addition to the primary effect on phase 0, being a sodium blocker, they also have some potassium channel blocking effects, which mean they also do this. Back to our fast response fiber action potential, they're going to do this and shift the entire action potential to the right. So the 1As all prolong the action potential and also the QT or QTC interval. Kind of think of it as like stretching out the action potential and apply that to like a surface EKG, right? So this is actually going to be from right about here where the Q wave would be to where the T wave is. So knowing that, you can predict that these are the medications that are really more notorious for causing drug-induced QTC prolongation in torsades. So we tend not to use them in practice, but they include some of the older medications, procainamide, and I'll just abbreviate some of these, quinidine, and then another one, let's put it up here, disopyramide. All right, so then moving on to the 1Bs, what these do, again, they're still sodium channel blockers, but they actually have the opposite effect. They don't affect phase 3 and cause more repolarization. They in fact actually shorten the action potential in the QTC, so they can be useful for patients that have a prolonged QTC at baseline. They include lidocaine, which is IV, and we have kind of an oral version of lidocaine called mexiletine. Now there is one other one that's not really used clinically, but it does have antiarrhythmic properties as a 1B, and that's phenytoin. So I'll note that there. The 1Cs include a couple of oral antiarrhythmics that actually are used for treating AFib and aflutter. They're really good for chemical cardioversion and for maintaining sinus rhythm in people that have structurally normal hearts. And they include flecainide and propafenone. Now these actually differ from the A's and the B's because they have a variable effect on the action potential and the QTC. So not really much appreciable effect. So that's the 1s. So then we have the 2s. Right? So the class 2s are our beta blockers. Think of beta blockers as being like indirect acting calcium channel blockers. So they're really going to affect the slow response fiber, which again, driven by calcium, right? And they're going to work in the SA and the AV node. So the beta blockers are really useful for rate control of atrial arrhythmias like AFib, aflutter. The class 3s then are potassium channel blockers. So kind of an easy trick to remember here is class 3 affects phase 3, which is potassium. So it's going to affect repolarization. So we have several antiarrhythmics in this class, and these are actually used a lot more commonly. So these are going to include amiodarone, which you're very familiar with, a very versatile antiarrhythmic. Has a lot of organ system toxicities, but it tends to be very effective for a lot of different types of arrhythmias. There's amiodarone's cousin, dronedarone, which is only oral, only used for AFib and flutter, and is a lot less versatile. Then we have sotalol, which can be given IV or orally. Can be used for AFib or flutter or for VTAC. So it is a beta blocker, but it's unique because it's the only beta blocker that has potassium channel blocking effects. And then we have 2 more, and these are the only 2 kind of pure potassium channel blockers. So we have dofetilide, which is oral. And then we have its cousin, which is only given intravenously, which is called ibutylide. And then the last class within Vaughan Williams are the calcium channel blockers. And recall that these are specifically the non-dihydropyridine calcium channel blockers. They're going to do the same things that beta blockers do, right? They're going to work over here in the slow response tissue on calcium in the SA and the AV node, and they're going to be very useful for rate control, just like the beta blockers, right? So this is diltiazem and verapamil. And then I'm going to kind of slide over here. So we have a few additional medications that don't really kind of fit nice and neatly into the Vaughan-Williams classification scheme, so we'll basically call these some of the miscellaneous antiarrhythmics. So recall we have digoxin, which works by slowing AV node conduction. So this is also going to do the same thing that beta blockers and calcium channel blockers do, but it works kind of indirectly by increasing vagal tone. It's not as effective as those other two classes. We also have adenosine, which is IV, and it's a nucleotide. It's very short-acting, and it's actually only useful really to treat supraventricular tachycardia. Sometimes it can help us diagnostically figure out what the arrhythmia is just by slowing it down enough. And then the last one is just a cation, which is magnesium, which we give for a patient that's got a low magnesium level with any type of arrhythmia, and it's also useful for treating torsades. So I hope you found this refresher here really helpful for your studies, and this makes a lot more sense. So with that said, thanks for your attention, and we'll see you in class. Good luck.